Good afternoon, everyone. It's Friday, and we are going for another episode of Overfilled, the podcast. I am Dr. Brooke Messer, and I'm joined by Dr. Jason Jedlicka and Dr. Jamie Kuzner. We're close friends, and we get together for our podcast. We try to get together weekly and talk about everything great that comes from our careers working with scleral lenses and the patients that come along with them. And so today we're going to talk about some scleral lens fitting challenges as it relates to conjunctival prolapse. But first, we're going to talk about what overfilled us in the last week. And so it's been about a week and a half since we were together. And so, Jamie, what's overfilling you this week?
All right. Well, I guess some of my new news, the team already knows here, but my overfilled is that I am going to be a rotation site for externs for Indiana starting next year. And I'm just so excited because that's something I've always wanted to do. I love teaching, but obviously I'm not at a university. So I am so excited that I'll be able to have a student with me to see all these really cool, interesting patients that we have. And then also teach them about running a practice and running a specialty lens practice. So I'm super excited. So I'm hoping that if there's any students watching from Indiana, check out my site. I know Jason is trying to put in a good word for his, favorite students to come join me in Detroit.
All of them are your favorite though, right?
Right.
I know. I'm just excited. I've been telling my patients that for years. Like when I first opened, like all of them just kept saying, like, it's just you by yourself. Are you going to hire another doctor? Or like, what is your plans? And my plan was always, my plan and goal is to have a student here, so that way I can teach. And that was when I opened this office. That's what I wanted, and I'm proud to say I did it. So I'm super excited about that. I have one overfilled crazy story because I don't know if you listen to the podcast enough, weird stuff happened to me, like a raccoon in my garage. So my overfilled negative this week was that we had an overfilled toilet that ran for an hour while we were out of the house, which overfilled my entire bathroom and overfilled the floor below it, the playroom of all my kids' toys. That, unfortunately, we had to throw away last night, and our basement. So we have water remediation team in there until Monday. It sounds like you're in a white noise machine, and so yeah, that was kind of sad. Overfilling of water in my house.
Yeah.
Yet another meaning for overfilled.
Oh my God. I'm like, there's always something crazy happening to me in my life. I swear. I'm like, you can never just have like an easy week. So yeah, that happened on Wednesday when we were at dance class with the girls, but come back to water just like pouring out of your lights. It's like, what the heck? What a freak random thing, right? So that's okay. The good news is my kids we'll be getting some new stuff, I guess, with our insurance check to replace all their favorite things. That was kind of sad, but that's all right. We'll make the most of it. We'll have a new cool playroom we get to redesign and bring in some new bigger kid stuff. So those are my overfilled. Happy, sad. That's okay.
Yeah.
Still going.
My that townhome that I bought in Minnetonka, Jason, the laundry machine leaked at one point, and I had actually one of my students that was rotating through there because I had moved in with Brian by then because we were just about married. And she said, like, do you have water spots above your kitchen cabinets? And I was like, I don't remember. Can you send me a picture? And it was like a ginormous,
no.
And she's like, I think it's
that's always been there.
Yeah. And I was like, no way. And I was actually at Academy that year when it was happening. And so had to send over Brian, of course, to manage it. And thankfully he was willing and able to do that. But I can echo the, it's stressful. And I didn't have a bunch of stuff lost because thankfully it didn't like pour through into the next floor. But just knowing that your ceiling is potentially, in danger, it's really stressful. But how about you, Jason? What's your week been like?
It's been good. And so my overfilled is a personal overfilled. As you guys know, grandfather now to, is he 4.5 months old? Anyway, this last weekend we did the apple orchard thing, which is a fall tradition, of course. And so I'm going to show a picture.
Oh, yay.
Look at that
little
nugget.
Guy. So anyway, Hans
Look
is
how hair
4.5
he
months
has
now.
Cute.
He's a good little kid. So I get to spend time with him on Saturday, which always makes for a good time. And of course, that's Kim, my wife.
Yep.
And so, yeah, that was a fun way to spend our Saturday. Getting apples.
Yeah, that's one to put on the Christmas card. That's such a cute.
Yeah, it's really good. So
nice.
Anyway, I just know that a day spent with him lowers my blood pressure, so it's good for me.
Yeah.
Oh,
Nice.
So anyway, that's all. Nothing from work this week. I'll have more work stuff next week.
Yeah, you always have lots of that. I usually talk about personal, but I'll talk about work this time. We have a 9-year-old boy who's been working with Ortho K lenses and came in for his dispense, got his lenses in, went home, and then 4 days in, he broke a lens. So we quickly reordered another one. And after he got the new one, because they come from Bismarck, so that's 3 hours from me, mom emails myself and some of my team members, and she's like, he cannot get this lens in, like just such a huge block. I talked to his optometrist in Bismarck, and she's like, yeah, I'll have him come in. We'll practice a bit. And so they tried to practice, really couldn't get anywhere. So they drove to Fargo. We saw him on Tuesday, and he was there for almost 2 hours, just trying different techniques, practicing. And he was able to let our team members put the lenses on, which we felt like was because he was having not really like anxiety, but he was just very, unsteady about it, very unsure. And then he got the lens in the next 2 nights. I didn't hear from mom today, but he did get the lenses on, when they drove back to Bismarck Tuesday night, and then Wednesday night he got the lenses on. Haven't worn them all night yet. He wakes up and takes them out, and we're not really sure what the change has been, because the first 4 nights he wore them, everything was going well. But it was kind of fun to see kind of take it back to basics and then go in. And I actually jumped in the exam room with him because my technician was like, gosh, I just don't know if he's going to get anywhere. And so then thankfully my schedule allowed me to go in and sit with him and go back to basics with insertion removal. I know, Jamie, you probably do a lot of insertion removal trainings, but at this point, like I don't do a whole lot. And so it was nice to just reconnect with him and hopefully instill some confidence in that each week. We just get a little bit further, and you just have to be patient with some of these young kids. You forget that like 9 years old is really young, and mom is motivated. He's motivated. He's a swimmer. So just kind of taking a step back and being patient was like a reflective moment for me this week. And I've been, I was happy for him to actually get something out of the 3-hour drive, so that he went home and had some success that night, even though it wasn't a full night. Yeah. So with that, we'll go ahead and load up we threw some pictures together on, when might you see conjunctival prolapse? What images, what would you be looking for in your evaluations that would kind of clue you in to, hey, I may see some conjunctival prolapse here based on a cornea scan like this. And also, just some tips and tricks on how we try and fix it if we feel the need to, because maybe sometimes we don't. And so we'll just go ahead and kind of kick it off on, Jason, do you want to comment on what you see here and how you might think about conj prolapse in relation to this image?
Yeah. So this is a curvature map. What I'm trying to decide what.
I think this one's an elevation map. I'm sorry, I got
elevation or tangential? Yeah, I was wondering that.
Oh, yeah,
I know
you're right.
the next one is tangential.
Okay. It's in microns. Okay. So then that must be what, pellucid, or what is that?
I think this one actually is post-refractive. I think it's like an RKI maybe.
Okay.
And the with the and basically what I was trying to get at, because this is my image.
Yeah, no, you're
so
right.
Maybe I should have kicked it off.
No.
Just that very big area of change there.
Well, I'm looking at the scale. So the gray is -40. Does it say?
The gray is -60 at the top.
60.
Okay. So that's elevation. Okay, so that's just really trenched out down there.
Right.
Yeah. Okay. So again, obviously, no matter what happens when you put a lens on that, you're going to have more clearance in the area of gray, white, pink, whatever, than you are anywhere else. And so there's going to be more room there. And so you're right. You could, in theory, you could fit a perfect lens and you could have prolapse there. And that, then you wouldn't, it's not like you failed. It's just you're fighting the anatomy of the eye and some, the lens decenters inferiorly. That creates more space. It's just going to be a brutal struggle to avoid having prolapse in that area, no matter what you do.
Yeah, and this patient, this was from before we had opportunities to do some of those dual and quad seg lens designs. And we did have that issue where we ended up with 400 microns over that area, 400 microns more than everywhere else. And so, really needed to work on. I think I ended up going from like a medium-sized lens to a smaller diameter lens just to try and decrease like the chamber altogether. And then also, I think I steepened the base curve a little bit, even though it's a oblate lens, but I just tried to make it less oblate, just to try and change the depth in that area, and wasn't able to completely get rid of the conjunctival prolapse, but was able to reduce it to a spot where you didn't quite see, like the tissue got kind of thick in the area, but it didn't completely fold over like sometimes you see. So the patient definitely had some relief. Sometimes patients comment about, they actually sometimes point to the area of conjunctival prolapse and say like, my eye feels tight or it hurts right here. And so they can feel that like tightness. And that's what this patient was having. So it wasn't a overly impressive image of the lens on the eye, but the patient was having symptoms, which is why we worked toward a resolution. And plus with RK, they always have such like weird potential for neo and everything that an RKI is maybe one that I would work a little harder at resolving than maybe just somebody who has keratoconus.
Sure.
If there was something to see there. The next one, Jason, is another image. And I think this one is this one's a curvature map. So this one's chin. So we can kind of talk about that again too. So the gray is the steeper areas, and the green, sorry, I can't zoom in. I can't really see what it is, but this is another post-refractive eye too.
The green looks like about 34 diopters there.
Yeah. And, very similar appearance in that it steepens toward the limbus inferiorly. So it's just a big old, gutter basically of the cornea being cut out. And
gutter of the cornea. That's
what's that? Gutter. Yeah.
The gutter of the cornea. I've never heard that terminology. I love it.
Yeah. So I guess maybe if it was upside down, granted, you could maybe see this in Terriens too, but I feel like the Terriens guttering is more obvious superiorly, or at least to me. Maybe it's technically, I think, 360, but so if this was a reverse image, I'd maybe consider it to be something like Terriens. But thinking back, I'm pretty sure this is another RKI. And I tend to see these types of things in oblate corneas, of course, because that's where we end up with these like bigger gaps between the lens and the peripheral cornea, and end up kind of with a challenging limbal clearance situation, trying to match that oblate shape to the cornea so that we have like nice optics and optimal clearance over the mid-peripheral area. And then you end up with kind of this mess of things sometimes in that periphery. We have pictures coming up, but so we can move into that. How often do you chase conjunctival prolapse, or what kind of cases do you try and get it to improve?
I think it's interesting, and no plug specifically for Zenlens, but since I've been doing a lot more biolevation, I don't have as much prolapse. And I think it's just because we're aligning the lens so much better, and we're not overvaulting the limbus in those areas. So it's interesting. I just feel like I used to see it a lot more years ago. And now that my fits have like refined more and that the technology has refined more, I don't have them as much. But I guess the fits that I would focus more on are more like maybe my graft patients too, because I just don't want any issues with like oxygen, especially if it's the prolapse is going all the way up to like even the graft host junction. I still remember when I first saw prolapse and I was a resident, and I freaked out, and I went and told Jason, and you just came in the room so nonchalant, and I'm like, I'm just so like, look at this area. I'm so worried about it. And you're just like, well, I mean, I'm not worried about it. You're just like, Jamie, I'm just not worried about it. I think it's fine. I think you did a fine fit. And I think a lot of us, especially newer fitters, myself included, when I first started, it's like you see the prolapse and you're just trying to chase it, and it's usually fine. It doesn't cause a lot of problems, but you almost need someone over your shoulder just saying like, it's okay.
Right.
It looks scarier than it is, right? What do you
Can,
think,
for
Jason?
sure. So let's go through some of these here.
Yeah. So that one is, those are yours, Jason. That,
Yeah,
you know,
so
that's an obvious heavy conj prolapse.
Right.
this is a heavy conj prolapse, but look at the prolapse. It doesn't look, there's not a lot of vascularization in the prolapse. The eye next to it is white and quiet. So again, the question being is, what would you do about it? In this case, I might not do anything, because in this case, the eye doesn't seem all that bothered by it.
Yeah. Yep. It's challenging. I think if I was early in my warranty, maybe I would just continue to work at it, but I wouldn't necessarily, get overly excited about it if the patient was comfortable.
And I'm pretty sure this patient has been in these lenses now for like 7 or 8 years with
it's
really no
fine.
issues. And I haven't even gone back and tried to fix it, even as our abilities to fix the fit have evolved and we can do a better job. She just doesn't really have any issues. So, this on the other hand, maybe, there's a little bit of redness at the limbus here in some areas. It doesn't look quite as quiet.
Right.
Maybe I'm more concerned about this one, even though there's less prolapse per se. But the eye itself doesn't look quite as happy underneath it. I don't know. What do you think?
I feel like it almost might be looking like a little tight at the bottom too.
Yeah. Or it's just like maybe
The lens.
inferior. Yeah. Like digging
Yeah.
in there, sitting low. And again, like you
Right.
were saying, Jamie, too, I agree that most of my pictures that I put together for this are a little older. Because I do think that being able to center the lens better with some of the techniques that we can now use has really decreased that, at least to keeping it in a lesser impressive appearance of that conjunctival prolapse. And here, the lens is probably low, the chamber is low, which is allowing for that, like, kind of limbal engorgement. And so we just do the best we can. And, sometimes I'll ask too about like how long the rebound redness sticks around after the lens comes out. And that helps me decide, is that eye still red in that same crescent, the next morning? And then in that case, I'd be more likely to want to change things around for the patient.
Okay, so
have
then
you guys ever? Oh, I was
picture I'm gonna
wondering.
show you.
What's the other picture?
Hang on, not this one. This one. You guys have probably all seen this one before.
Oh yeah.
Okay. So I presented this picture at an educators conference like 5 years ago. And this is the same patient, obviously. And on the right eye, you can see debris under the lens, right? Look in the pupil. I mean, look how foggy the pupil looks. And then if you look at the other eye, the pupil looks clear. So there's no debris on the picture on your right, his left eye. However, the picture on the right has prolapse. And interestingly enough, I would even go as far as to say his pupil looks a little bit bigger. I don't know. Would you agree?
I mean, slightly,
Maybe.
but I don't know. That could be
very slightly. Okay. All right. So what's the difference between these two pictures?
one of them sealed off and one of them's open.
Right. One of them is sealed off and the other one is not. So the picture on the right, which is the left eye, clearly the lens is suctioned to the eye. And the patient is very happy with this eye. Right? The lens on the left side, his right eye, the patient is very unhappy because his vision's foggy.
Right.
Yeah.
Okay. So I presented this to a conference and I asked the audience, I said, which eye would you rather have be the good fit? Which one is a successful fit and which is the bad fit? And it was basically 50-50 split. Okay. So I think the important thing is to recognize is you will not get prolapse if you don't have a semi-sealed environment. So if you ever really, 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 really don't want prolapse, make the lens fit looser and make it wiggle around and jiggle around and have the tear exchange and all that stuff. And you won't get prolapse, right? But you'll have a bunch of other issues.
Right.
So in a quest to try to eliminate prolapse, sometimes you can buy yourself other problems. And that's one of the reasons to not, maybe always necessary. Now, again, I will say, is the pupil bigger on the left side also because we are suctioning the entire anterior chamber up into the back of the lens?
What? I don't know about that.
Of course,
Could it just be like the picture, or the lighting, or like?
Of course, we're pulling the cornea and the iris and everything up into the back of the lens. So is that having a pupil dilating effect slightly?
What do you
I'm
think,
just
Brooke?
saying, we don't know the answer. I don't know the answers. I'm just trying to be observant about these things. And if somebody smarter than me can figure it out. What would be interesting, though, is to have, compare pupil sizes in eyes wearing a semi-sealed scleral lens to an eye without.
Yeah. The OCT capabilities that we have nowadays in measuring some of those angles and stuff would be interesting to see if anything changes or how much change. We can't deny there's change. Patients have vision warpage when their lenses come out, especially eyes that have had surgery on them before. And so the cornea is getting warped under the lens from that suction. And it's just a matter of how much and how visually significant. It would be interesting to take a big group of patients with various conditions and then see how much changes and see if that correlates to the condition that they have. Do RK patients change the most, which is what I would guess.
I would guess so too, or LASIK patients.
Yep. And then,
thinner cornea.
severe KC patients, of course, mild KC changes a little bit less, corneal integrity and all that, of course. But that would be interesting to see. And it sounds like a good resident project.
So,
there you go, Brooke.
So along those same lines, because we've got studies which show that when you have a patient in a scleral lens and you take the lens off and do topography, it shows it the flattening of the cornea, right? So why is that? Because if the lens is pulling the cornea up into the back of the lens, it should be pulling the central cornea more than the peripheral because it's thinner, right? So why don't we see a steepening of the cornea from scleral lenses?
I don't know. What's the answer?
I don't know, but
yeah.
One thought I have is that we measure the topography after we take out the scleral lens. We're not measuring it with the scleral lens on the eye still. Is there a way that we can actually measure the corneal shape where the scleral lens is still on the eye? You see what I'm saying? Can we somehow measure the shape of the cornea through the contact lens? Because I would hazard to say that part of why it is flattened is because when the lens is on the eye and it's suctioning the cornea up, it's pulling it up. And then when you remove the lens, the lack of suction makes the cornea collapse back down, and it may collapse more centrally faster than peripherally. I don't know.
My other thought is, does it have something to do with, even the low percent of corneal swelling? Does that temporarily change curvature?
It's possible.
Yeah. It's true.
All right. What else do we have for pictures here, Brooke?
Well, these are just images of conj prolapse on like how this one here, what I wanted to point out was the angle of the cornea versus the angle of the lens approach. It's just too steep. And so in a perfect world, we'd want that, mid-peripheral, kind of exactly where like the green numbers are. Again, limbal clearance is like closer to where it hits, where that junction of you can kind of see where the lens bends to change into the landing curves. That's further to the right, but it's that the curve, where we would call it the smart curve, I guess, in our Zen lens world. But, that mid-peripheral chamber is like what needs to change to be more evenly, aligned or parallel to the cornea. And then it's when you get that steep lens approach to the surface of that corneal limbal area. So that was kind of what I wanted to bring up here was this is what we need to look for, because even changing the limbal clearance might help a little bit, but limbal curves are so small. It's hard to make a really big, hundreds of microns of change. Like sometimes we need from just a tiny limbal curve. And so that's where, in all lens designs, changing the base curve and the limbal curve can hopefully, decreasing chamber size too, is making sure that you're not too big and making sure you're centered can be helpful.
So have you guys have either of you taken a situation like this and measured with OCT your limbal clearances and then quadrant specifically adjusted limbal clearances to optimize them? Like in this case, you could, if you went with like an echo, you could certainly bring this limbal clearance down by whatever you wanted to.
I have not done a quad limbal. Have you, Brooke?
I have, and that's the one that I've used a few times with, if you go to the other big OCT picture, Jason, is it one back?
Mhm. Oh, is
This,
that the same eye?
This is a different eye.
Okay.
But this guy, I think, actually does have Terrians.
Mhm.
But again, what I wanted to show here, Jason, where you were talking about was like, this one has like conj prolapse in one, and then he's loose in the other meridian because of how crazy his cornea is in the area where his Terrians is most prominent. And so then you can just see all the fogging in that chamber. And so it's, you know, getting everything to align and, you know, because the lens is, in this case, this conj prolapse is kind of superior nasal. So I'm sure the lens is falling inferior temporal and it's just kind of pulling all that stuff in there. And again, this is a crazy eye because his cornea is actually steep superior because of his Terrians. That it has made a challenge. And he was one of my first echo patients. And so I, you know, really stunk at fitting it because I didn't really know what I was doing. But we eventually got him there, you know, like 11 lenses later or something like that. As I was trying to figure out my quad sags and limbal clearances and stuff. But the one that actually worked, Jamie, where I did have quad limbal clearances was this super proud graft. And I don't know if you look in the you know, promotional world out there for the Zen Lens Echo, it's probably out there somewhere. But we maxed out the lens depth with the lathe. So we couldn't do any more bi-elevation or quad elevation because we just couldn't, the lens couldn't go deeper. So we had to manage it through base curve and limbal clearances to try and get the smart curve to compensate for the chamber size. And it was you, Jason, who suggested some of those things and helped me out with that. So yeah.
What's really, again, I think is interesting, and I tend to poo-poo using the OCT a lot for fitting, but in some of these quadrant specific lenses like echo or anything where you can quadrant specific any of the zones. I wonder if I'm missing out by not doing more OCT imaging so that you can really nail down your clearances the best you possibly can. Because I feel like even on this picture, like if this were my patient and I had this OCT, I would probably get real nitpicky about some of these clearances and say, how can I bring this down and this in and all that? And there's probably ways that if you just looked at it with the naked eye with fluorescein, you probably would think, it looks pretty good. But you could probably get a lot more precise in this case, especially on some of these really bizarre eyes, especially if you've already moved into a quadrant specific chamber and a quadrant specific haptic and everything is quadrant specific. Yeah, like again, we've all fitted quadrant specific like echo type lenses, but how often do we refine the fit with OCT? I don't, but maybe that's something to be considered. It'd be great if somebody out there had done an echo and had some OCTs where they refined it by looking at the OCT clearances and then adjusting a certain amount to compensate. So there's a call to action. Anybody has?
Yeah,
that's what I've been doing with my echoes. I feel like I can't believe you don't use your OCT for your echoes because it's like
I'm lazy.
That's what I do. I do like the 4, you know, you do all the quadrants, and even though I have an eaglet, like I still feel like once the lens is there, like then the eaglet doesn't help you at that point. Like when you're refining it, you still if we're gonna do an echo, we're gonna be precise. You know what I mean?
Yeah.
Like I want to be able to measure it exactly.
Yeah.
Having these really wide 16.5mm scans is really helpful because it does kind of give you more of the entire lens relationship, like positioning and things like that. It's much harder to determine lens centering and that kind of stuff. Is it, you know, which way is it sitting with the, you know, 8mm scan? And so if I just had the normal OCT, I probably wouldn't use it as much as I do because of this. Like I can do 32 cuts, you know, almost 17mm out. And you know, in that radial fashion. And so I feel like when I can do that, it gives me a lot of information on maybe seeing something that I previously wouldn't have. So, and you know, it's patients really like these images too. So another part. And this particular instrument is really fast, so it's not a pain. Like I can just ask a technician, in our technician chat, ask somebody to do it, and they'll jump at it, because if they don't jump at this, they might get asked to go do a visual field or something. And this instrument, the Anterion, is much easier to do. This eye here is this one is an interesting guy. He had a corneal transplant or two in his history. And he was in an anhydrous exposure. So he was in a chemical spill. So he's got all the things. He's got glaucoma. Thankfully, it's a mild glaucoma, but still uses a decent number of drops, and has had that corneal transplant. At 9 o'clock there's like a little lipid leak right along the graft host junction. But he has kind of a very proud sort of graft, and that sort of diagonal looking vasculature streaks at 6 o'clock. That's all Conj prolapse there, because he really does have that corneal shelf. And I've worked on him for so long. He comes to Fargo now, but he was an Edina patient. And the other eye wears a iPrint Pro, and it's similar. This one is I think this one is a Zen lens, just a typical scleral. And he prefers the comfort of this lens over his other one, but vice versa on the other eye. And just a challenge. I mean, when you have such odd shaped eyes and you have to put a spherical chamber on it to fix the optics, this is just what you end up with. But that conjunctival prolapse has kind of been a thorn in my side for a long time, just because his eye always looks just like this, blanched in the periphery of the landing curves, and then all that limbal vasculature closer to the cornea, which has made me nervous.
Some of that's probably unavoidable given his history. I mean, he may have some limbal stem cell deficiency given his history. So you have to always put in the context of what's going on with this eye, and is all that redness and stuff, is that all related to your lens fit, or is that just his eye?
Yeah. I would agree. He definitely has. I would absolutely bet he has stem cell issues. And he's always in great spirits, and sometimes I make him come back and he's like, I don't even know why I'm still coming, so he's doing okay. Yeah. So
question for you guys about, I know none of us use this tool, fenestrations. And what do we think about people using like fenestrations in like the limbal areas to reduce suction and to reduce, Conj prolapse? I mean, I haven't done fenestrations. I don't think either of you have done them also. I mean, it sounds like in theory it would work great. I think it'd be interesting, a topic to talk about in the future, just fenestrations, because I want to learn more about them. I just have no way to do them. And how do I know?
Well, you do have a way to do them.
Well, I mean,
buy yourself a little tool, and it's only $35 on Amazon.
I know. And so it's I wonder too.
I have one patient in an iPrint that had 2 fenestrations placed, superior temporal and superior nasal, because that's where he felt like the lens was very tight. And otherwise the fitting was doing well. And he came back and said that now superiorly it feels so much better, but now inferiorly bothers him. So we're trying one more with a triangle of fenestrations, but limited experience there. But we'll definitely have to have Beta on sometime to talk about those.
Well, here's the thing about fenestrating too, is you have to remember that, because I used to fit only fenestrated lenses for years, right? And when you fit a fenestrated lens, you're going to get less suction, or you're not going to get suction theoretically if you do it right. And so you're not going to lose as much vault, right? So you can fit the eye with a little less clearance, because it's not going to pull up the cornea as much. You're not going to lose as much clearance, which is necessary, because if you fit with too much clearance, you're going to end up with bubbles. So the lens has to be rotationally stable, because you can't have it going all over the place really. And then B, you've got to put the fenestrations in the right place. And I've just seen some pictures online recently where, I think some of the talk about fenestrating lenses has got more and more people doing it on their own. And I've seen some interesting pictures of some ones that have not looked good, and it, for a variety of reasons. So there's a little bit of a trick to it. But again, I think fitting the lens with a little less clearance and making sure you get the fenestrations in the right place, they definitely can work. They're obviously a little trickier to get on, because they won't keep the fluid underneath as well. But they don't need to keep the fluid underneath as well. So it's all, it's just about getting comfortable with it. And I think, again, you need to start somewhere if you're going to start, and you have to pick an easy patient, one that's willing to work with you and has a lot of awareness of their situation so that they can report back if things seem wrong.
Yeah.
But anyway.
Yeah, well, I think that was a great discussion on suction and conj prolapse in general, and we can make a half hour out of anything, but there you see our call to action there, standing call to action always. Please send us your cases, especially those that are maybe giving you a little bit of some trouble. We would love to help talk it through with you. You can send a video of yourself, or you can just send pictures of the lenses with a description. But would love to get some fellow fitters images up here. You can send your information to overfilledthepodcast@gmail.com, or you can find us at overfilled_the podcast on Instagram, and we're also on Facebook. So there's lots of ways to connect with us, and looking forward to hearing from you all. Otherwise, we will plan to see you in another week or so. Keep fitting and overfilling.